Welcome and thank you for joining us today. My name is Jen Marchetti. I am the Patient Engagement Chair for the Pheo Para Alliance. I had a pheochromocytoma in 2015, and I know how difficult it can be to navigate a rare disease. I also know how important it is to have factual, up-to-date information to help navigate these neuroendocrine tumors. I'm thankful for the PPA and the experts that share vital medical knowledge on Pheo Para so we all can be well-informed and active participants in our healthcare. I'm here today with Doctors Ruth Casey and Christina Pamporaki to bring you this webinar on pediatric Pheo Para. I will introduce our experts in depth in a few moments. This program is brought to you by Pheo Para Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. A special thanks to Novartis for funding this webinar. There are a few upcoming events I'd like to share with you all. This Sunday, June 22nd, we will be attending the SNMMI meeting in New Orleans, Louisiana, for their Patient Engagement Day, where attendees will learn about nuclear medicine. This information is specifically useful and especially useful for patients in metastatic and unresectable disease. Join us live in Louisiana or virtually. We have two upcoming peer support meetings. One is July 1st at 5:30 Pacific time and 8:30 Eastern time. And another one, Thursday, July 31st at 9 a.m. Pacific time, noon Eastern time, and 6 p.m. Central Europe time. Saturday, September 13th, is our annual gala in Boston. And Saturday, September 20th, in Montreal, Quebec, Canada, there is an in-person patient conference. This event will be free and held in collaboration with CNETs. You can find out more about these events and other events on our website at pheopara.org. The PPA has resources dedicated to educating parents and guardians about Pheo Para kids. This webpage is pheopara.org/education/PheoParaKids. And we will put this link in the chat, so don't worry if you didn't get that. Also, you can find on this page a short animation video for kids over 9 years of age, and it helps explain the illness to children. Today's agenda will include our experts presenting information on recently released international consensus guidelines on pediatric pheochromocytoma and paraganglioma. Then we will hold a questions and answer session. If you have questions, you can type them into the chat section at any time, and we will do our best to answer as many questions as time allows. The information presented on this website is for educational purposes only. It should not be substituted for the advice of your doctors and your medical team, because they have the in-depth knowledge of your medical history and your child's medical history in your current situation. Now, let me introduce our experts. We have shortened their bios considerably, but their experience and expertise is wide. Most importantly, related to this session, they are co-authors of the recently released International Consensus Statement on Diagnosis and Management of Pheochromocytoma and Paraganglioma in Children and Adolescents. Dr. Ruth Casey is a consultant endocrinologist in Cambridge University Hospital NHS Foundation Trust, and holds an academic position as a senior research associate in the Department of Medical Genetics in Cambridge University. Dr. Christina Pamporaki currently holds the position of senior endocrinologist at the University Hospital Carl Gustav Karas, Dresden, where she also serves as head of the Clinical Research Adrenal Unit. I'm happy to hand this program over to our two experts.
Also for
Christina,
on behalf of Ruth. Oh, you cannot hear me?
We can now. Sorry, we couldn't for a second. We can hear you now.
Yeah, now you can hear me? Yes. So I would like to thank again for the very kind invitation and the nice introduction. And I will just start the presentation also on behalf of Dr. Ruth Casey. We will discuss today about the diagnosis and management of pheochromocytoma and paraganglioma in children. So, can you see my screen in full modus?
Yes, yeah.
Great. Then let's start. So, we know that pheochromocytomas and paragangliomas, that we will also refer to these tumors as PPGL, are much more often in adult than in pediatric patients. In fact, the pediatric PPGL accounts for 10 to 20% of all PPGL cases, and its estimated annual incidence is 0.5 to 2 children per million per year. The biology of the childhood PPGL is different to the adult tumors. In particular, children present with a higher prevalence of multifocal and metastatic disease, which is mainly attributed to the higher prevalence of hereditary disease in children than adults. In particular, hereditary disease is up to 80% in children. Before to the year 2024, there was no existing guideline or recommendation for the diagnosis and management of PPGL in children. So as I already mentioned, PPGL has a strong hereditary basis with more than 25 susceptibility genes identified to date. But the vast majority of hereditary cases in children belong to a specific cluster. In particular, we have cluster 1 tumors, which are tumors that are due to pseudohypoxia signaling pathways, and they include pathogenic variants in genes such as VHL or SDH or fumarate hydratase, which are shown here with this pink purple color. These cluster 1 tumors that are more prominent in children are less differentiated and more aggressive with a higher risk of metastatic disease. If we want to summarize the differences between pediatric and adult PPGL, we would say that children present with a higher prevalence of hereditary disease compared to adults, which is mainly attributed to pathogenic variants in genes that belong to cluster 1. So these cluster 1 tumors have specific biochemical phenotype, and there are more often noradrenergic tumors, which means that in the biochemical workup they present with higher concentrations of normetanephrine, but they show no elevations in metanephrine. These cluster 1 tumors are also more often multifocal in children and extraadrenal, and they are also associated with a higher prevalence of metastatic disease, which also in children is more often non-synchronous. Non-synchronous means that the metastatic disease is usually diagnosed at least a year after the initial tumor diagnosis. So as you can see from these figures, there are quite some differences between pediatric and adult PPGL. So in the year 2024, we have published international consensus statement on the diagnosis and management of pheochromocytoma and paraganglioma in children and adolescents. For this, we have used the Delphi process, and we had a task force of 40 specialists from 11 different countries. Consensus was reached for 39 statements. And as consensus, we defined agreement between the specialists, which was higher than 75%. There were 3 subsequent rounds, and during the last round, The statements were also graded with A, strong, if the agreement was higher than 85%, or with B, weak, if the agreement was between 75 and 84%. Importantly, after consensus of the statements, we looked at the literature and we have graded our statements according to the quality of evidence that is available in the literature. And we have graded, therefore, our recommendations and statements with either very low, low, moderate, or high quality. One of the most important statements of the consensus was about clinical suspicion of PPGL. We know that signs and symptoms of PPGL in children are mainly dominated by the manifestations of catecholamine excess. So many children are diagnosed with paroxysmal hypertension. Nevertheless, sometimes hypertension may not be prevalent during the evaluation in the clinic. So pediatricians should not discount such a tumor if children present with other signs and symptoms of catecholamine excess, such as palpitations, sweating, pallor, nausea or vomiting, headaches. There are some children also present with polyuria, visual disturbances, or even worsening performance at school. Nevertheless, we have to appreciate that the vast majority of children that are tested for PPGL are children with pathogenic variants in known susceptibility genes that are under surveillance programs. And we should also appreciate that PPGL are very slow-growing tumors. It may take 6 to 9 years from 1 centimeter tumor to grow to 2 centimeters, and more 6 to 9 years for a 2 centimeter tumor to grow to 3 centimeters. From this, we understand that children that are under surveillance programs most likely will be diagnosed at a very early stage of tumor development, where the tumor is still too small to produce sufficient amount of catecholamines to cause signs and symptoms of catecholamine excess. In other words, among children that are under surveillance program, most of them may be totally asymptomatic at the time of diagnosis. The same also applies for the more rare group of children that are tested for PPGL due to an adrenal or extra-adrenal mass that is incidentally found during imaging studies that are performed for unrelated reasons. Also, in these children, most likely the tumor will be diagnosed at an early stage of development, and most likely also these children may not present any signs and symptoms of catecholamine excess. Another important statement that we should mention is the biochemical testing. Although most cohorts and studies are based on adult cohorts, most studies that study the biochemical testing are based on adult cohorts, we know that for the biochemical testing of children with PPGL, we should include either plasma-free or urine levels of norepinephrine and metanephrine. And these measurements should be performed using liquid chromatography methods. It is also important to appreciate that norepinephrine and metanephrine vary between children of different ages and between boys and girls. This means that we should have for children specific upper cutoffs for norepinephrine and metanephrine. And if our labs do not have these upper cutoffs, then they should use the ones that are provided online in the international guidelines. So every positive test result should be followed up. If we have a child with a previous history of PPGL or a child with a pathogenic variant in a known susceptibility gene, then we can tell that this child belongs to the category of high risk for having the tumor. In such cases, in such children that are at high risk for the tumor, if possible and available, we should prefer the plasma-free norepinephrine and metanephrine, as this test shows a slightly better diagnostic performance compared to the urinary metanephrines for children at high risk for the disease. In addition, with the plasma metabolites, we also have the chance to add an extra metabolite, methoxytyramine. Methoxytyramine is a metabolite of dopamine, and it helps us identify the more rare dopamine-producing tumors, such as some head and neck paragangliomas. So If we see elevations of 2 or more metabolites, or elevations of a single metabolite but above the twofold above the upper cutoff, then we can proceed to imaging studies. If though we see in our test results an elevation of only a single metabolite, and this is in the gray zone, I mean less than twofold above the upper cutoff, then we should be very careful and we should check if all pre and analytical precautions have been followed correctly. For instance, we should check if the child was sick at the time of at the day of the blood sampling. We should also check if the child was at the supine position for at least 20 minutes before blood sampling. We should check if the child was fasted if we include methoxytyrem in the panel. We should also check if the metanephrines were measured with appropriate methods, liquid spectrometric methods, and if appropriate age-adjusted and sex-adjusted upper cutoffs are used. If all these pre and analytical precautions were followed correctly, then we can proceed to imaging. So something of this was not followed correctly or the child was sick, then we should repeat the blood sampling under proper conditions. For children that are tested due to signs and symptoms of catecholamine excess, we say that these children are at low risk for the tumor. In this case, we can choose either among plasma-free metanephrines or urinary metanephrines. And again, if we have elevation of a single metabolite only in the gray zone, then we can repeat the testing in 2 or 3 months. But if we have elevations of 2 or more metabolites or elevations of a single metabolite but higher than twofold above the upper cutoff, we can proceed directly to imaging.
I'm going to take over from here, Christina.
Yeah.
So hello, everybody, and thanks to Christina for starting the presentation. So I'm going to now proceed and I'll hand back to Christina towards the end of the presentation. So as Christina has just said, most children diagnosed with pheochromocytomas and paragangliomas come to our attention either because they present with signs or symptoms of catecholamine excess and then go on to have biochemical testing, as we've just heard, or occasionally children may come to our attention because they are undergoing screening because there is a known genetic diagnosis that runs in a family. A question that is frequently asked is if biochemical testing is positive and we have run through all of the pre-analytical and analytical considerations that Christina has just mentioned, and we have to proceed to imaging studies, then a frequent question is what imaging tests should we do? And really at that point, the pre-test probability that the child has a pheochromocytoma or paraganglioma is going to be quite high because you've already done the biochemical testing. And therefore, the argument is that we should be using the most sensitive test to try and identify a pheochromocytoma and paraganglioma, and that is either going to be a CT scan or an MRI. Now, both of these tests are imperfect, particularly in children. For example, for a CT that involves exposing the child to a dose of radiation. However, a CT can give very important anatomical information, which will often be required by our surgeons to try and plan a surgery, if indeed we do confirm a diagnosis of a pheochromocytoma or paraganglioma. And also a CT rarely requires sedation because it's typically a quicker test for a child. On the other side, an MRI scan will often require sedation for a young child, but does not come at the same risk of radiation. And the final imaging modality that might be considered is an ultrasound, and that is a test that's frequently done in children. However, in our consensus guideline, we have mentioned ultrasound, but also said that it is unlikely to be the best test to do if the pre-test probability or if the suspicion of pheochromocytoma or paraganglioma is high, because it gives very limited anatomical information and certainly wouldn't give enough anatomical information for a surgeon to go ahead and plan a surgery. The other thing to be aware of when looking at CT and MRI scans in children is that the same rules don't apply that we use in the adult population to characterize or help determine what an adrenal nodule might be. Importantly, if you are doing a CT or MRI in a child, it's usually because you already have, as I say, suspicion that that child has a pheochromocytoma or paraganglioma. And there are some red flags that we need to be aware of in terms of radiological characteristics that might raise suspicion of a more malignant behaving adrenal mass. And that includes a larger size of the tumor, so greater than 5 centimeters. If it looks very hypervascular, if it has what we call heterogeneity, so that means that the texture of the tumor doesn't look the same throughout. And obviously, if there's any signs of the tumor invading local structures, they would all be what we would call red flags on a scan. So if we just go to the next slide, Christina. So in our consensus statement, we recommended that for children who have biochemically confirmed evidence of a pheochromocytoma or paraganglioma, that we would recommend either MRI or CT to try and localize the tumor. And which test you use will really depend on the local expertise and on the MDT that this case is discussed at. But either MRI or CT are reasonable choices to localize a pheochromocytoma or paraganglioma. After that, some children may also be recommended to have additional imaging, or what we call functional imaging, or sometimes it's referred to as nuclear imaging. And this will typically involve a type of PET-CT. It's not required for every child, but might be required for children who have evidence, for example, of larger tumors, or in whom there might be a suspicion of potentially metastatic disease. And so we frequently use molecular imaging to identify patients who might have metastatic disease, or, for example, in children who have biochemical evidence of a pheochromocytoma or paraganglioma, but if the CT or MRI fails to identify a tumor, then we may choose to do a PET-CT, which sometimes gives us more information on where the tumor might be. And so in the consensus statement, we've also provided advice as to the exact kind of PET-CT and the exact indication when you might consider a specific type of PET-CT. And the choice of PET-CT or functional imaging or nuclear imaging can also be determined based on the genetic status of the child, which would hopefully be known at the time that the test is being arranged. We've also provided some information about what tests you would choose if you either didn't know the genetic status of the child or if the child didn't have a pathogenic genetic variant. So we can go to the next slide, Christina. Okay, so we've talked an awful lot about the hereditary potential or the hereditary risk of pheochromocytomas and paragangliomas in children presenting with these tumors. And as Christina has already said, about 80% of children who present with pheos and paragangliomas will have a genetic predisposition. It's therefore not surprising that in our international consensus statement, we've recommended that every child who presents with a pheochromocytoma and paraganglioma should be offered germline genetic testing. And in most centres, germline genetic testing will typically involve testing a panel of at least 10 genes, and they're the most common genes implicated in hereditary pheochromocytoma and paraganglioma. Of course, if any child is identified as harbouring a pathogenic variant in a PPGL predisposition gene, if it's not already known in the family, then the genetic diagnosis in that child should trigger testing of all first-degree family relatives. You can go to the next slide, Christina. And this data shown in this slide here is actually data taken from a paper that Christina and colleagues published a few years ago, where again they looked at the differences in the genetic diagnoses in children presenting with pheochromocytoma and paragangliomas versus adults presenting with pheos and paragangliomas. And as Christina has shown in earlier slides, the main difference is that we see much higher rates of what we call cluster 1 gene variants in children compared to adults. And we've just highlighted some of those genes here in red. So some of the most common cluster 1 genes that we see in children presenting with pheochromocytoma and paraganglioma are the SDHB gene, the von Hippel-Lindau gene or VHL, and SDHD. And as you can see, hopefully, although the print is small, the rates were much higher in the pediatric patients than in the adult patients. We can just progress. And similarly, although we see some patients, the other cluster of genes, which is called cluster 2, and this includes genes such as the RET gene. If we just go back for a second, Christina. The RET gene and NF1, for example, although we do see occasionally children presenting with pheochromocytomas with these genes, they're much less common in children than they are in adults. So the main message, I think, is that cluster 1 genes are much more common in children compared to adults, and cluster 2 genes, the reverse is true. So we see cluster 2 genes much more commonly in adult patients compared to children, although we test for all of these genes in any child who presents with a pheochromocytoma and paraganglioma. So we can go to the next slide. So what if the child has germline genetic testing, but the genetic testing comes back as negative? Well, we've just said that germline genetic testing is likely to harbor a positive result in about 80% of children, but of course the remaining 20% won't have a germline genetic diagnosis. And what should happen for those children? Well, the recommendation is that for those children, they should be referred to an expert center, and that might be the center that the child is already at. And at that center, there should be some consideration given to either sequencing of the tumor, if the child has the tumor removed, or consideration of whole genome sequencing of either the blood, so the germline DNA, or the tumor DNA, or occasionally both. And why would we do that? Well, we do that because of the 20% of children who don't have a germline genetic diagnosis, we know that within that 20%, a further 30 to 40% are likely to have a genetic change that's unique to the tumor, which may influence that child's long-term follow-up and management, although it's unlikely to influence any management for the family, because in that situation, that genetic change would not be hereditary. So the recommendation is that for children who don't have a germline genetic diagnosis after testing, that they be referred to a center or be referred to their local center for discussion about additional genetic testing of either the tumor or whole genome sequencing. Next slide. Okay, so we've spoken a lot about what the recommendations were in the international consensus statement and some of the important things to consider. And I think what's really important for us to emphasize is that pheochromocytomas and paragangliomas are very rare tumors in children, and other diagnoses are often much more common in children. And for that reason, it is always difficult to diagnose these tumors. And I think this case that I wanted to present just shows you some of the, if you like, obstacles that we face as we try to diagnose these rare tumors in children. And also helps to highlight how some of the diagnostic tests that we have mentioned in our consensus statement can really help to solidify a diagnosis and influence management for children. So this is a case of a 12-year-old boy. So he presented with 4 days of vomiting and abdominal pain. And when he was examined at the local hospital, he was found to be unwell. He was dehydrated, and he did have a palpable mass in his tummy on examination. Also, what was quite remarkable when they examined this child was that he was quite hypertensive. So this blood pressure is quite high for a young boy. His initial blood work showed that he had an elevated creatinine, so he had what we would call an acute kidney injury. So his kidneys didn't look like they were functioning efficiently at the time of his presentation, but they improved quite quickly with fluid resuscitation. So this all looked like initial dehydration. When he first came in, because the initial diagnosis was not that of a pheochromocytoma or paraganglioma, it was just of a very unwell, dehydrated young boy, they did an ultrasound of his abdomen, and this showed a very large mass in his lower abdomen. If you go to the next slide, Christina. So this is what after the ultrasound scan, this young boy went on to have a CT scan, and this is what it showed. So the red arrow shows the mass, which was a very large, irregular mass, which didn't seem to be arising from any particular organ. It wasn't arising from the adrenals. So it was at this point, the diagnosis was unclear, but the pediatric doctors who saw this patient when he first presented wondered, could this be a lymphoma? And the initial plan was to send him to our center, to the center that I work in Cambridge, to consider some central lines, to think about a biopsy potentially, or even a bone marrow biopsy, as at this point the working diagnosis was potentially lymphoma. If we go to the next slide. But I mentioned one of the more notable findings for this young boy when he presented was the blood pressure. So his blood pressure was quite high, and a very astute pediatric colleague took a further history from the family and from this young boy when he moved to our center. And they ascertained that this young boy had a 2-year history of intermittent symptoms, which included fatigue, vomiting, sweating, headache, and these symptoms were particularly bad when he exercised. The team noted that he didn't have a good explanation for his high blood pressure, and that the blood pressure wasn't responding to the typical treatment that a high blood pressure should respond to in a young child. They also noted that he had blurred vision, and when they did an ophthalmological examination, they saw some changes in the back of his eye and the retina, which were consistent with more chronically elevated blood pressure. So this looked like that this young boy had high blood pressure for some time. So they They quite rightly re-reviewed the imaging with the pediatric radiologist at that time, and putting all of this together, so a young boy with abdominal pain, a large pelvic mass, and a history of what now looks like long-standing high blood pressure, the radiologist confirmed that this large mass that we can see in the CT scan was likely arising from the organ of Zuckerkandl, which is a common location for an extra-adrenal paraganglioma. If you move to the next slide. And quite rightly, before organizing any biopsy or anything like that, the team got in touch with me and our pediatric endocrinology colleagues, who we recommended urgent plasma metanephrines. And as you can see, this patient had a markedly elevated plasma norepinephrine level, but also had an elevated 3-methoxytyramine level, which Christina has spoken about. Because his mass was very large, we were concerned that this patient may have metastatic disease or indeed multifocal synchronous paragangliomas. So we carried out a gallium dotatate PET CT, and what you can see here is that yes, he has this large paraganglioma in the pelvis, but he also has a second synchronous paraganglioma up here. This is a mediastinal paraganglioma, and less well appreciated on this image, but better seen on this image, he had a third synchronous paraganglioma, smaller, in his abdomen. So I think what's really important at this point was that he was in a center where we see a lot of patients with pheochromocytomas and paragangliomas. We recognized that this young boy had a very high likelihood of a genetic predisposition, and he had urgent genetic testing, which confirms that he had a pathogenic variant in the SDHB gene. This was important because that helped us explain that these multiple tumors that we could see on the gallium dotatate PET CT were unlikely to be secondaries or metastases, which was a concern from some of our colleagues, but more likely to be synchronous tumors, because synchronous tumors are more common in patients with cluster 1 gene mutations or SDHB gene mutations. And this ultimately was very important in progressing this young boy's management, because we were able to say that he should have surgery, because these don't represent metastatic deposits. These represent multiple primary paragangliomas. If we go to the next slide, Christina. So this patient was offered alpha blockade, so phenoxybenzamine, which is an alpha blocker, which we use to try and control the effects of the elevated circulating catecholamine levels to help reduce blood pressure and keep patients safe, particularly as we plan surgery. And after we had initiated a good dose of alpha blockade, he unfortunately remained quite tachycardic, so we had to introduce some beta blockades. That's what propranolol was. And then about 6 to 8 weeks later, the patient was offered surgery. So he had staged surgery. So initially he had surgery on the large abdominal or large pelvic mass and the second smaller abdominal tumor that you could see on the scan. And then just about a year and a bit later, we operated on the mediastinal paraganglioma. And the reason why we did it that way was obviously we wanted to allow this patient to recover from the first surgery. And secondly, we know that tumors in the mediastinum are less likely to be aggressive or behave in a malignant way. And also the tumor in the mediastinum was not making hormone. And we could tell that because when we measured his hormone levels after his initial abdominal surgery, they had normalized. So I think if we just progress, Christina. Yeah, so here we can just see what his hormone levels look like before and after surgery. Okay, so I think this case just highlights a typical presentation of how children can sometimes present. It can be confusing, especially for pediatric colleagues who don't see these tumors very often in clinical practice. But some of the really important things for us to remember and for us to advocate for young children and for families is that high blood pressure should raise some red flags about these rare tumors, and we should avoid biopsy in any child in whom we think there's a possible diagnosis of pheochromocytoma or paraganglioma until we have biochemical testing. And at that point, if a Pheo or paraganglioma is confirmed, we need to be discussing these patients at expert centres to get the appropriate management initiated as soon as possible. So I mentioned that this young boy was started on alpha blockade and beta blockade. So again, in our guidelines, we provide some oversights on the exact medications that can be initiated for patients, so alpha blockers, and the doses that need to be considered based on the weight of the child, and also some of the side effects that we need to be aware of when these medications are started. Generally speaking, the recommendation is that all children who are being prepared for surgery with a pheochromocytoma or paraganglioma should be started on alpha blockade. And if the patient's heart rate cannot be well controlled despite adequate fluid replacement and on adequate doses of alpha blockade, then we might need to think about including or starting some beta blockade to control heart rate. But for many young patients, alpha blockade alone is sufficient. So again, if there's any confusion or any doubt about what dose or what medications might be appropriate to use in a child when starting alpha blockade ahead of a planned surgery, again, I'd recommend that you refer to the International Consensus Statement, because we've provided a good bit of detail in this table here, which I won't go through now in the interest of time. So if we progress to the next slide. Oh, sorry, just to also say that when we start these medications, we are aiming to achieve a heart rate and a blood pressure. So a blood pressure which is less than the 90th percentile and a heart rate between the 10th and 90th percentile, using age-appropriate reference ranges for that individual child. So that is the target that we aim for with these medications before surgery. Great. So what kind of surgery should we be doing? Well, I think the very important thing to say is that the type of surgery is very much dependent on the individual, the location of the tumor, the size of the tumor, and these are all aspects of patients' care that really need to be discussed at expert MDTs. But in the International Consensus Statement, we have provided some generic advice about surgical approaches. So, for example, we've recommended that it is appropriate to consider a minimally invasive surgery, so that is a laparoscopic surgery in children. But we would advise caution in a minimally invasive approach if we just advance, Christina, if the tumor is greater than 5 centimeters, or if there's any evidence of local invasion or any evidence of adjacent lymph nodes which look suspicious to be metastatic, and obviously if there's any evidence, as I say, of any local or distant spread on preoperative imaging, in which case we would want an open surgical approach as opposed to a minimally invasive surgical approach. We've also provided some guidance about when to consider cortical sparing or partial adrenalectomies. And this is an approach that we consider in any patient, including children, who are at risk of bilateral pheochromocytoma. So that means a pheochromocytoma on the right and left adrenal. And the reason why we might consider a partial adrenalectomy in that situation is because the adrenal gland makes some very important hormones, including cortisol and mineralocorticoids, which keep us well. And we can compensate very well with one adrenal, but without either adrenal, we would need lifelong replacement of both glucocorticoids and mineralocorticoids. And we know that there is significant morbidity and, in fact, unfortunately, mortality associated with needing to take lifelong replacement glucocorticoid and mineralocorticoid. So for that reason, for patients who have genetic predisposition, which places them at risk of bilateral pheochromocytomas, depending on the gene, we recommend that we try to do some adrenal preserving surgery such that you remove the pheochromocytoma but try and leave the part of the adrenal that makes glucocorticoid and mineralocorticoid intact. And so that is currently recommended for children with VHL and RET gene variants, but we do not recommend it for children with SDH gene variants. And that's because there's a higher risk of malignant behaving tumors with the SDH genes. And in that situation, we would unfortunately recommend completion or total adrenalectomy to reduce the risk of leaving any disease behind. Just progress, Christina. Yeah. To the next slide. So as I said, we would just recommend MDT discussion for these patients. So what about after surgery then? So we've gotten through surgery, and how do we follow up a child following surgery? So we'd again recommend that plasma or urinary levels of norepinephrine and epinephrine, and if performed preoperatively, 3-methoxytyramine, should be repeated between 2 and 8 weeks after the surgery. If a child, for whatever reason, didn't have full staging, either using MRI, CT, or a PET scan before surgery, then we would recommend that they have post-operative staging at 3 to 6 months to make sure that the child, or that we have achieved complete surgical remission for that child. Just progress, Christina. And for every child, the follow-up should be in a dedicated clinic. The discussion of the specific follow-up should be discussed at an MDT, and there are a number of factors which we look at to help decide and tailor what the follow-up long-term should be for that individual child, including, for example, whether the child does or doesn't have metastatic disease, whether the child has a germline pathogenic variant, what the tumor size was before it was surgically removed, where the tumor was located, and we may even also take into account the secretory phenotype, so the biochemistry of the tumor before it was removed. And all of those factors will help us decide how long the child needs to be followed up, how frequently they need to be seen, and what tests they need to have when they come to clinic. We just go to the next slide. And so that's exactly what we've recommended in the international consensus statement. And if I just quickly show you the table, if you just progress, Christina. So this is a very, very busy table, but just to highlight that we have been quite prescriptive in what we think the follow-up should be, both in terms of duration, frequency of follow-up, and the exact tests that should be done. And that prescription, if you like, or that recipe has been tailored to the genetic status of the child. And we've also provided some information about the follow-up should the child have a negative genetic result, so not be identified as having a germline genetic variant. And we've also provided some advice for children with what we call red flags. So this might be a child who doesn't have a genetic diagnosis, but who has other red flags. And if we just progress, Christina, those red flags include a tumor size greater than 5 centimeters if the tumor was located outside the adrenal gland, if the patient had multiple tumors, or if there's a family history of pheochromocytomas and paragangliomas despite a negative germline genetic result. So those risk factors will be taken into account, and that the surveillance will be tailored even if the child has a negative genetic result. So we go to the next slide, Christina.
So thank you, Ruth.
So I think
and we can proceed with the next slide. And the next slide is about sporadic cases. So even if children show negative genetic test results, they should be follow up for long term, because we know that even children with negative genetic testing, they have high prevalence of recurrent disease, which is up to 14%, including recurrences at more than 10 years after diagnosis. The nature and the time interval of the follow-up is again individualized according to tumor size, tumor location, biochemical phenotype, and age. So a recent study, which was also including children, showed that patients with large tumor size or extraadrenal tumor location or noradrenergic biochemical phenotype in younger patients had higher risk for recurrent disease. So these patients should be followed up more intensively. And again, as Ruth has mentioned earlier, even for patients with negative genetic testing, we should always test and investigate for somatic mutations, which have been identified in up to 30% of the pediatric PPGL cases. So with regard to the management of metastatic PPGL, treatment options in children with pheochromocytoma and paraganglioma should be individualized and directed by a multidisciplinary team. If complete tumor resection is not possible, debulking surgery should be considered in all children with metastatic PPGL. Local treatment approaches can also be considered as general treatment options to reduce symptoms and signs of catecholamine excess, to reduce metastatic related pain, to treat oligometastasis, and generally to improve prognosis. Systemic treatment should be considered in children with high tumor burden, which also usually have disease progression. In particular, targeted molecular radiotherapies are a treatment option in children with high tumor burden, and of course with tumor lesions that have avidity for the corresponding diagnostic radionuclide, and they do not have disease progression. The radioactive compound that is mostly studied in children is the radioactive MIBG. Nevertheless, peptide receptor radionuclide therapy has also been used in pediatric patients and has shown very promising results. And these promising results have led to the treatment of children with PRRTs, and this can be done in the setting of a clinical trial. Now, for the systemic chemotherapy, which includes cyclophosphamide, vincristine, and dacarbazine treatment, can be considered in children with high tumor burden and rapid disease progression, or children where treatments with targeted molecular radiotherapies were not successful and the tumor is still progressing. An alternative of the systemic chemotherapy with CVD is temozolomide. Temozolomide is an analog of dacarbazine and has been used in pediatric patients with metastatic PPGL and has shown promising results, especially among children with SDHB pathogenic variants. We can also use and consider treatments such as like HIF2 alpha inhibitors. The so-known Belzutifan has been recently approved for treatment of children with advanced local and unresected metastatic PPGL. So we have many options. Now, with regard to children that have pathogenic variants in tumor susceptibility genes but have never presented the PPGL, these children should be screened under specific surveillance programs. The surveillance strategies have been considered and constructed under consideration of the penetrance of the tumor, under consideration of clinical and biochemical phenotype, the metastatic risk, and of course, under consideration of the other non-PPGL related manifestations of the specific hereditary syndrome. In other words, according to the specific gene, we know at which age we should start screening the child, what is the clinical evaluation and the biochemical test that we should use, and if radiological surveillance is needed. So with the current guidelines, we have made considerable advances in the diagnosis and management of PPGL in children. Nevertheless, there are many remaining challenges. In the consensus statement, we support the wide-scale adoption of family clinics for families affected by PPGL or for families with individuals carrying pathogenic variant and tumor susceptibility genes. We also support and encourage the participation of children in national and international registries, as well as in international clinical trials. And there are many open trials right now where children, especially those that are older than 12 years, can participate. Most of these studies are oriented in the targeted radiotherapy treatment, and we also have a study on Belzutifan. And with this slide, I would like to thank you for your attention, and we're very happy to take questions.
Thank you, ladies. I know as a pheochromocytoma patient myself, even as an adult, the information that you shared, it was eye-opening and beneficial for me as well. And I'm a sporadic pheochromocytoma patient, but still that information is very helpful if I see signs or symptoms in my children or my grandchildren. So I really appreciated the information you shared personally. So we have a few questions. I have some on that I need to grab from my phone that they came in on. So give me a second here to ask, how do you manage incidentally found tumors in an asymptomatic SDHB patient if the tumor is not easily resectable? I know you mentioned it, but if you could just go over that again, because that question was asked a couple times.
Okay, do you want me to take that, Christina?
Yeah, of course.
Yeah. Okay, so this, if I'm correct, this is so the question is that if we find something incidental on a scan, the child is asymptomatic, but the child has genetic diagnosis. So I suppose the first question is the incidental finding a paraganglioma or a pheochromocytoma? And we should hopefully be able to answer that by both reviewing the radiology and the biochemistry. So if the biochemistry is negative, that of course does not exclude a paraganglioma, because we know that some paragangliomas, particularly in any patient, including children with an SDH variant, for example, can have what we call non-functioning or non-secretory paragangliomas. So in that situation, you could look to, for example, use functional imaging to help confirm the diagnosis of a paraganglioma. So you could, for example, use dose type PET-CT, which is quite specific, again, to confirm the diagnosis. And for the most part, if you confirm the diagnosis of a paraganglioma, even if it's non-functioning, and if the child is asymptomatic, you may still choose to recommend surgery depending on where it is, depending on the location. And if they're saying that it is not easily operated or not easy to operate on, then it becomes a benefit risk, consideration. And I suppose in that situation, you would probably opt to monitor it very closely. And if there was any sign of growth, then you may have to either reconsider surgery, discuss with your surgical team, and if they still think that's not possible, to potentially seek a second surgical opinion.
Thank you. That was more in depth, and I appreciate you sharing that, since that question was asked a few times. Another question, and I'm not sure how much we can get into this, but I recall seeing a new drug that is potentially available to treat these tumors. So that may be more of the United States question. You did briefly come up with, there are some medications that children can use, but if you could answer that for us.
Yes, I can add on that. We have, like, perhaps it is temozolomide that it's relatively new and we use under clinical trials. It is the analog of dacarbazine treatment that I told you, and we have recently got a permission to use Belzutifan in children older than 12 years for locally advanced and unresectable metastatic PPGL. Of course, there are many other treatments that can be tested and used off-label, like tyrosine kinase inhibitors. But I think if we refer to something that has been recently approved, I suppose that they mean the Belzutifan. Exactly, the HIF2 inhibitors.
Yes, that was just recently approved here in the United States back in May. So I believe that is it as well. In patients with NEM2 who are found to have an adrenal tumor suspected of being clinically silent pheochromocytoma and a normal biochemistry, is adrenal blockage necessary?
May I answer that? Or Ruth, do you want to step in?
Yeah. No, you go ahead.
First of all, we have to be very careful with what we say clinically silent and biochemically silent. Tumors in cluster 2, like men, are tumors that are not very often secretory, which means that patients may have great time intervals where they have no signs and symptoms. So they may be clinically silent indeed. But we should be very careful because these tumors are not biochemically negative. And when we say biochemically negative, we should make sure that we use the appropriate tests with appropriate methods and with appropriate upper cutoffs. For instance, if we use immunoassays and not spectrometric methods, we have the risk of missing almost 1/3 of patients with PPGL, which means that is it truly biochemically negative or is it a false biochemical negative result? So first of all, we should consider doing the appropriate tests and using appropriate reference intervals. So it may be so the case that we have a very small tumor at an early stage of development when it is still too small to produce sufficient amounts of catecholamines and metanephrine so that they can show a positive biochemical signal. In this case, so if we talk about a tumor of 1 centimeter or 1.2 centimeter, for instance, that has normal metanephrines near the upper cutoff, but not pathological, in this case, we are not obliged to block the patient. But what I do is that if the tumor is a pheochromocytoma and indeed it is a man, I would even very, very carefully block the child, because when we go to operate this tumor, we have to appreciate that this tumor is full with catecholamines. and it has also very dense secretory granules. So if the surgeon during the operation cuts the tumor, or during the anesthesia we may have a catecholamine secretion, then the patient is under risk for complications. So even in this case, if we have biochemically negative small tumors, one could consider to block, but it's not very only basic block, but it's not wrong if we do not block, because as I said, the tumor is too small to produce enough catecholamines. But if we have a larger tumor, then we should really consider if it is we have wrong biochemical test results.
Thank you. Can you please clarify how knowing the somatic variant driving a PPGL in a germline negative patient would impact management? Is that the same answer, or is there a little different?
Yeah, I mean, I can take that if you like. So, so it's tricky. So basically, there are some somatic variants that we will only detect based on tumor sequencing, but they may actually be present in more cells than just the tumor cells. It's what we call mosaic variants. So these are variants that aren't in every single cell of a patient, but they are variants that are in some but not all. So the variants might not be detected if you do blood sequencing, because they may not happen to be in the cells that were sequenced when the blood was sampled, but they will tend to be present in high frequency in the tumor. So we can detect those kinds of genetic changes if we sequence the tumor. And the reason why we would want to know that is because if we detect what we call a mosaic variant by sequencing the tumor, then that patient will typically be followed up as we would follow up somebody with a germline variant, because we can't be certain how many cells in their body are affected by the gene. So they're potentially at risk lifelong of developing other tumors. So that's one reason, and that is a complicated scenario to try and explain to patients and families. But that is one reason why we might sequence the tumor. And the other reason is because increasingly we may find genetic changes that are specifically unique to the tumor. These aren't mosaic, these aren't germline, they are unique to the tumor, but they may help us decide if that patient may benefit from a specific type of therapy, for example, if that patient has metastatic disease. So a really good example is if we picked up an EPAS1 variant or a HIF2 alpha variant in a tumor, then that patient may benefit specifically from Belzutifan, for example. So they're just two reasons, just two examples of why we would encourage additional genetic testing in any child who has negative germline gene testing.
So ladies, we're just about done with our time, but we have a couple of other questions. Do you have a few extra minutes for us?
Yes, of course.
Okay, so I have a question just from what Dr. Casey was saying. And it kind of is being the patient. So I, as a parent, let's say, I have it's considered sporadic, but my tumor wasn't tested because it was so long ago, and I was only tested via blood. Would I want to be tested again in case there is another variant? So I do get tested every couple of years, especially if there's a new variant. But is this something, speaking to what you just spoke about, Dr. Casey, where the blood might be a little, it's not as, what's the word I'm looking for, reliable as the tumor test?
No, I think so. I think the blood is very reliable for hereditary genes, so genes that we can pass down, genes that we can inherit. If you have what I spoke about earlier on, if we detect one of those mosaic variants, there is no data at this point to suggest that they are hereditary. They theoretically can be, but at the moment in clinical practice, we wouldn't have a way of knowing whether they were hereditary, because you would have to test multiple different types of tissue. For example, you would have to test ovarian tissue or testicular tissue to see if the gene happened to be in those cells. And at the moment, it wouldn't be recommended to do genetic testing on family members if you picked up a mosaic variant. And if you pick up a somatic variant, which is one that's only in the tumor, then there is no risk to family members there either. So I suppose the simple answer to that question is There's a lot of reassurance in having a negative or a normal germline genetic test in terms of the risk to other family members.
Perfect. Thank you. Yes, I was a little confused and I was listening very well to that one. So this one, I'm going to end it with this one. And I think as a parent myself, this is somewhat of it's an important question. How do we address the psychological impact of a diagnosis such as a pheochromocytoma or a paraganglioma in children and their families?
So I can just briefly cover that in our consensus guidelines. We have a statement where we suggest and we recommend that there is psychological support by a psychologist in not only to the child but also to the family. And that should be not only at the diagnosis, but through the whole management and surveillance of the child. So psychological support is of paramount importance, and it has shown in studies that it's important not only for the quality of life, but also for the whole prognosis. So yes, you're absolutely right. We fully support psychological support at every stage.
Perfect. Yes, it's very important for our children to have that, because as an adult, it is very hard to have this diagnosis. So as a child or being a parent of a child who has it, that is a lot. And I appreciate you answering that for us and that there is support. So I'm going to close this program. I'd like to thank both of you ladies for joining us and your dedication to our community. It is doctors who share this information and help us be fully knowledgeable as best we can to navigate these, especially for our children. So I thank you. This webinar will be available in a few days on YouTube and the website, and you will be able to see certain parts of like the questions also that will be divided up for you. Please look at social media and our website for any upcoming events or information that we share. Updated information is always on social media, as well as pheopara.org, our website. Thank you again, Novartis, for their support and sharing this episode for us. And thank you everyone who attended. Have a fearless day.